pleased to see so many people. It's lovely, and from such diverse backgrounds. So I've got to do welcome and housekeeping. The rules are pretty usual, so stay on mute unless you're speaking, just to avoid the dogs in the background, which is what will happen with me. Use the hand raise function if you want to talk. Can you all introduce yourself in the chat? This is too big a group to do a proper welcome, so introduce yourselves in the chat function. Just to let you know, we're recording the presentations and the discussions in the main room, and they'll be uploaded onto the Coalition for Personalised Care website. There will be time for questions at the end of the presentations, but again, use the chat function. Emma from the Coalition is monitoring all that, and we'll make sure that questions in the chat are answered. And we'll try and answer all the questions posed, but if there are too many, then we'll come back to you, those of you that haven't had your questions answered. We're breaking to smaller groups after the presentations, and we're going to ask you to feedback on key points, either using the Jamboard, and we'll talk you through that beforehand, or use the chat function. The breakout rooms themselves will not be recorded, so we will only know what you said and all the brilliance of what you said if you write it down somewhere for us. And we are producing a report after the discussion, and so share links. If there are relevant links to this discussion, do share those through the chat as well, so that our report is as comprehensive as it possibly can be. So the purpose of this event is, well, there's two drivers for it really. Integrated care systems are tasked with addressing health inequalities in their area, and the NHS England has set expectations about how ICSs should work with communities and people, and we've got up there on the slide the 10 principles on working with people and communities, in a link to that particular quote. Now, this roundtable then provides an opportunity for health colleagues, particularly those working in ICSs, to get a better understanding of how community strengthening activities can address health inequalities of all kinds. I should say, before I hand over to Brian, we are very conscious that we've got 4 white male speakers, which was accidental, but we've just realised that. And this is an event devoted to addressing health inequalities. So we're hoping that the diversity of the rest of you is going to help address that, so that we've got a real range of views and experiences to contribute to the debate. So our chair is Dr. Brian Fisher, and he qualified as a GP in 1976, working in South East London until his retirement just a few years ago. And you're not really retired, are you, Brian? Campaigned for the NHS and social care for many years. There's a dog in the background, I'm sorry. And he's on the steering group of End Social Care Disgrace, which is a broad-based campaign to transform social care. He's a director of the Health Creation Alliance, which promotes health creation through community strengthening and other approaches. And it's within that context that he's chairing this event. Honorary researcher at King's and Guy's Primary Care Department in the Medical School, and at Imperial Medical Cot School in the Primary Care and Public Health Departments. He's published many peer-reviewed papers on community development and on people having online access to their GP records. I could go on. I'll end, though, by saying that Brian was awarded an MBE for community development in 2007. So, Brian, over to you.
Gosh, that's a hard act to follow. So yes, welcome everybody. Thank you very much for being here. It's going to be a great event, and thank you very much for your involvement and your energy that you're going to contribute to all of this. I think there are probably 2 other elements to this that I think we want to emphasize, that we want to get out of this event. One is sort of support and ammunition, perhaps, for organizations who want to move towards community strengthening. So, for instance, the evidence, I hope, will be able to give you some data and ideas that you can present to your finance directors or to clinicians if you want to persuade people that this is an important, relevant thing to do. And secondly, we are hoping for pledges and action as a result of this. So if there are things that as the event goes on that you feel you can commit to, then we will try and draw those out at the end. So please keep thinking about that. How does this apply to you? How does this apply to your area and your area of work? And the final aim really is to try, if people are willing, if all of us are willing, if some of us are willing, to get together subsequently and exert a sort of pincer movement, a grassroots and statutory sector combined pressure on government, this government, the next government, to really push on community strengthening and to integrate it as business as usual into the NHS, into local authority. We need health creation, community strengthening as the sort of fabric of our health services and local authority services going forward. So I'm hoping that this will be a great and useful event, and that this is a start. I'm going to present this section on the evidence base for community strengthening, and I hope that we can then use that as a base to move on. This is a very brief, a sort of rather galloping summary of the paper that I think you've all been circulated. So I don't suppose you've read it, but if this stimulates the juices and you want to read it later on and use it for your and your community's benefit, that'd be great. So these are the things I'm going to be talking about over the next 15 minutes or so. And as I say, it'll be quite a rush, but we should get through it all. Let's kick off with the definitions. So this is what we mean by community strengthening approaches. Approaches that enable communities to set their agenda and raising issues that matter to them. So this is not necessarily the same agenda as the NHS, not necessarily the same agenda as local authorities, but it is the community's agenda that we want, that needs to be incorporated into the planning and development of the statutory sector. So working with other sectors, statutory or otherwise, to respond to those issues. So it's about action, and it's about involving communities to take more control. The Health Creation Alliance started off the concept of health creation, which is now pretty current. And what we mean is that health creation is the process through which individuals and communities gain a sense of purpose, hope, mastery, and control over their own lives and immediate environment. And I'll show you some of the evidence that health and well-being is enhanced and that health inequalities can be tackled to some degree through health creation. And it's a useful concept because it brings together a whole set of ideas that are really key to this arena. So community strengthening, community-led development, place-based working, social action, collective agency to address the wider determinants of health and develop approaches to health inequalities and population health that really do make a difference. So public health are pretty bought into this idea of community strengthening. This is Public Health England as was, that they see that placing communities at the heart of public health, empowering people to have a greater say in their lives and health, can reduce health inequalities and create connected and more cohesive communities, which has an impact on people's health. So let's start looking in more detail. Social contacts and our ability to take control help us to keep healthy. So this is a paper, a meta-analysis, so bringing together many other papers across over 300,000 people, that there's a 50% increased likelihood of survival for people with stronger social relationships. And it's an impact of enormous power. So it's comparable to risks such as smoking or alcohol. And you can reverse those risks by supporting people to have better links with each other. Here is a bit of the paper. Just focus on the red lines first, which are the impact of social relationships on mortality. And you can compare them with the more conventional black lines, which is smoking, alcohol consumption, flu vaccination, and so on. So you can see that the impact of bringing people together is of enormous significance for all of our health. We don't really know the details of how this happens, but we think that social networks, when people are brought together, we increase their contact, we increase our confidence, and that enables people to take more control over their lives and their areas, and that helps them to become not only more able to do things, negotiate with services, actually find jobs and so on, but it also makes people stronger and more resilient, and that's obviously particularly important in the current climate of economic adversity. And community strengthening approaches make this more likely to happen. A bit more detail. So looking first of all at improvements in health generally, the Mid and East Antrim partnership, we'll hear a couple of issues from them as we go through. Listen to older people's experiences and suggestions. Physical and mental health scores improved. People felt more in control of their illnesses, and they felt less lonely. A community development in Lewisham, in my patch of southeast London, developed by Public Health, involved community development workers working with the community, but focusing much more on primary care and on behavioral changes in health behavior. Some very substantial improvements in health behaviors, smoking, diet, and physical activity. And there are many, many studies that show that taking more control, enabling communities to have more control, has very significant protective mental health impact, both on Black communities, older communities, and in really very severe aspects of mental health, but suicide, for instance, and other elements too. So these are very good evidence that there are general improvements in physical and mental health as a result of community strengthening. This is data from Wigan. You've probably heard of the Wigan Council New Deal, where staff were supported to act in a much more collaborative and supportive way to the communities that they served, so a much more sort of community strengthening approach. And over time, so this is many years, we're talking about 10 plus years, there are very many elements of health that have improved compared to similar areas to Wigan. So deaths from cancer, alcohol related hospital admissions, smoking prevalence, suicide rate, physically active adults, all of these improved more, and in some degrees actually in contrast to comparator areas to Wigan. So that's across a whole local authority. This is the message that I hope I can bang through to all of us as a result of the data that we accumulated over time. So community strengthening also can have an impact on policy and on social determinants. Here are some examples. So in Dallas, there was a collective between the community and local academics. And again, over a period of 10 years or so, they really transformed the way that community functioned in relation to its health. They produced a healthy living center. They produced a diabetes center, a separate building, and they developed a free clinic system across Dallas, which of course in the States is a very dramatic and different kind of service. There are lots and lots of examples to show that joint decision-making between community and the statutory sector has enormous benefits, resisting threats to neighbourhoods, attracting resources, improving reciprocity and trust between people, challenging unhealthy conditions. So all of those have been demonstrated in lots of different studies. There's another final one in Kansas. Again, I think this was between academics and the community, which over time made a substantial difference to policies in relation to housing, to youth, crime and safety, and economic development. And I think the feelings in that local community have been very improved and changed as a result of this kind of work. We have data both from abroad and in the UK on crime and social cohesion. So in Toronto, a result of community strengthening showed some very dramatic reductions in crime. And in the Beacon project, which we'll refer to a couple of times, which was based in Cornwall and in Balsall Heath in Birmingham, similar community development kind approaches. There was a substantial fall in violent crime and in unemployment. So it was actually jobs became easier for people to find, and certainly the Beacon project has had very substantial impact on their community there. So the evidence suggests that community strengthening, various approaches to community strengthening can achieve these all at the same time. Statutory services become more responsive. It can promote health protection and community resilience. It can help tackle health inequalities and has an impact on behaviour change. And there is some data on money and on time and demand. It's quite difficult to do this work on social return on investment, but there have been quite a few studies. And in general, it looks as though for every pound the system spends on this kind of work, you get somewhere between £2 and £3 back. So the Antrim work did a very nice study which showed £2.38 return for about £250,000 invested across 4 authorities. The social return was £3.5 million. The Beacon project, which was the one in Cornwall I mentioned before, had a substantial benefit cost ratio. It ran for a long time, and so I think it probably accumulated benefit to the residents and to the services. And we have some impact on demand, it seems. So community strengthening can also generally seems to have impact on secondary care services. So Nesta did a big meta-analysis a few years ago suggesting about 7% savings, mainly on these hospital attendances and admissions. There's a community strengthening work in Newcastle that we're going to hear about later on, which saved substantial amounts of money and resources. There's a data looking specifically at the way community strengthening had an impact on heart disease, and it suggested that community strengthening was really comparable to sort of medical care and statins in its impact on heart disease. And the Partnerships for Older People's Project, the POPs project, which again was some time ago now, showed that by listening to older people and responding to the issues that they raised, there are substantial improvements in secondary care and primary care demand. So it all looks pretty good, really, from the data and evidence point of view, but it's not that straightforward. So there are a few caveats and a few extra thoughts. One is that particularly now, with the cost of living crisis, crushing economic and social inequalities make it much harder to deliver community control. That's been shown in lots of different places. So we have to be aware of that. Top down, I think, has been repeatedly shown to work less well than bottom up. So we are talking about community control here. And if as we move, hopefully, in this direction, we have to think very differently about how this gets incorporated into run-of-the-mill business as usual. There is no single model. We'll be hearing from a few different models after me, but I'm going to suggest to show you one community development model. Measuring the impact of these is tricky, but there might be a solution, and I'll just briefly mention that at the end. So this is an example again from the Beacon project. This was kicked off by a health visitor who then developed some various community development approaches. She met people on the estate. They got together, they talked across the estate to a large number of people and identified the issues that mattered to them. And then they brought in the statutory sector to help respond to those issues. They had particularly productive relationship with the police and with housing, and together that transformed the estate, but they also managed to get a new GP surgery and so on as a result of negotiating with the NHS. So that's one example of how this can make a difference, one approach. As I say, we'll be hearing from others. And this is, I've spoken to a number of academics about measuring social capital, which is one way of thinking about the impact of community strengthening. We know that as social capital increases, then health also increases. So this is a way of monitoring this approach. So if we were able to get measurements of this sort everywhere, then the chances are that it'd be much more likely that community strengthening would become business as usual. So this is one question: could your neighbours be counted on to intervene in various ways? And here are some examples. So this is one question. And the other is, please rate how much you agree or disagree with the following statements. And I think you can see the kind of thing that they're getting at. And you can, this is apparently, it's been going for 20 years, as I understand it. It's been shown to be valid, to be reproducible, to change over time, and it's used in many different countries and different languages. So this seems to be a very simple measurement that we could endorse and we could possibly use as a routine part of all our work. So that's the end of my presentation. I hope that's been helpful. I'm ready to take questions. I will try and stop sharing. There. Is that it? Back to normal functioning. Great. So are there questions and are there queries in the chat that people want to raise? Bit of a gallop, I know, but does this meet any needs? Guy, thank you.
Thank you very much, Brian. Of course, it meets a need. It's a hugely valuable collection of the disparate and collectively very convincing evidence for, I'm sure, most of the people on the call. My question is, why do you think it isn't more widely adopted? Why do you think this is still dependent so heavily on the fantastic health visitor in Cornwall who set off? Why are we relying on individual passion to give us these opportunities? Which I think is probably, you know, an important question for all of us, isn't it?
Absolutely. I'd be interested to know what other people think. Yes, we are at the moment almost entirely dependent on heroes putting their heads above the parapet and trying to do this work, often at great personal expense, and it's not straightforward work either. So over the years, I think the underlying problem is about power and fear. So this is not expensive. This could easily be done. It could easily be done through the ARSS program. It could just be said, if you want to employ community development or local area coordinators or whatever. So this is not expensive, but it is very demanding in terms of shifting people's culture, shifting people's ideas. And I think the NHS in particular, about which I know much more than the local authority, is frightened about relinquishing power, sharing power with other people. And the image that I think about sometimes, and I suggested this to Mark the other day, was that I think people think about this sort of power sharing, shared decision-making sharing, as a sort of seesaw. So either you have more power or you have less power. If you give more power to somebody, somebody else has less power. And I don't think it's really like that. It's much more like a set of candles. You light one candle and you use that candle to light the next one and the next one. So everybody gets more light. It's much more of a collaboration and a sharing than it is a power imbalance. But that's what I think the root problem is. It's not money. It's about attitudes and opinions, I think. What do others think, more importantly? Okay, I've stunned people into silence. Hello, Adam, and then Francis.
Just a really quick question, Brian. That was a really incredibly helpful run through the evidence. You mentioned a couple of times that it's quite difficult to gather the evidence or gather solid evidence on some aspects of community strengthening. I think you said particularly around identifying return on investment. And I think you also mentioned about the impact on demand. Could you say a little bit about why that's the case and what the challenges are for gathering evidence in those areas?
Can I ask Guy perhaps to deal with that? Because I think that he'll be talking about that to some extent later. So he succeeded in getting data. We tried to do it as well as part of a Department of Health funded study. It's extremely detailed work. I mean, you have to look at changes in demand, you have to look in very many different data sets, GP records. It's just complicated, and you're making many assumptions about what the impact of doing things differently is likely to be. But I charge Guy with the task of trying to answer that aspect of it. Francis, and then Victoria, and then I think we need to move on.
Brian, thank you for that presentation, and I agree with Pip's comment completely about the analogy. I think it's really helpful, and I wonder if we could look at focusing more on shifting the mindset around the mental model of that shift away from the deficit mindset that I think is really, that idea of the seesaw. If we take from you, if we give to you, we lose. And I mean, I saw an article only this morning about a story about a GP not being able to find a job, and that it was about the R's roles and that other people were being appointed as and at the end of the story, it was clear that this newly qualified GP had actually got a job. But it was a really indicative example for me about how there's that fear of change, particularly away from establishment ideas of how we do things, and that possibly the best way to combat that is by having the kind of collaboration of stories and having more people who have years of experience, as you have, Brian, in this world, saying actually no, it does work. And that repetition and repetition of stories is the way that we could perhaps redraw a bit of a balance.
I think that's very helpful. I must say I'm slightly more of a Stalinist than you about this sort of thing. So I'm also very keen that we look at government and see what possibilities there are to make it much easier for this sort of thing to happen. But I do agree, it is very much about making the case, making it as easy as possible for people to shift their mindset. Victoria.
Yeah, so I work for a community organisation up in Yorkshire, and we very much work on the basis of strengthening communities. And in a former role that I had as a public health intelligence lead, actually as a health visitor, so there must be something to do with health visitors here. We were tasked with actually going out into the community, finding out what they wanted, what services they wanted, and then working collaboratively with the local authority and working with schools as well as the experts in their communities. So proof that it does actually work and we can get those services into those communities, but it's the services that they want, not what we feel that they need.
Nice summary. If you've got data on it, send it in, please.
Yeah.
Eggs and figs would be very helpful always to get out. So good. Well, thank you very much, everybody, for that. Do look at the paper and use it as ammunition wherever you can. So now we're going to have 3 presentations, examples in a bit more detail than Victoria has suggested. We're going to start with Nick Sinclair, who's Director of Local Area Coordination in England and Wales for Community Catalysts. Take it away, Nick. You've got 10 minutes, and then we'll hear from the other 2 presenters, and then we'll have questions after that.
Thanks, Brian. Thanks for that fascinating review and presentation. I really appreciated that, and I think hopefully I can talk to some of that in this presentation too in 10 minutes. So I better crack on with it. I also want to share with you someone's story as for the most part of my presentation, because I think that would just help to contextualize things a bit better than what I can do. So yeah, as Brian said, I work for a company called Community Catalysts. Many of you will be familiar with. Community Catalysts is the home of local area coordination in terms of its development. It's the national development organisation for the approach, working in partnership with a number of local authorities and their partners in health to develop it and grow it in the country. And we also convene the network of areas who are doing it. Briefly, by means of a background, this as a well-established international approach, and that was born in the 1980s in Western Australia. As I mentioned, these local area coordinators that I'm going to be talking about are employed by councils, so they have this kind of foot in 2 worlds really, and I'm going to talk about the how a lot more after we've heard this story in a minute. But they're employed by local authorities, funded across the system, and a large amount of the funding that's coming for their roles is through health, NHS organisations. There's 120 of them in total at the moment, and these are all the different areas where they're working across the country, and they work in hyper-local areas of about between 8,000 to 10,000 population, very much based in those communities, with those communities, alongside those communities. So the reach is about 1 million or so people who could draw upon the time and support and input of a local area coordinator if they wished. And as I mentioned, they work very closely together as a network as well that we convene and support as part of our work. Just very briefly, a local area coordinator is not a coordinator of a local area. They're a coordinator in a local area. And hopefully this video that I'm going to share now, which is Dee's story. Dee is a citizen of York, reflecting on her journey and the experiences of local area coordination, and her local area coordinator Sarah alongside, just helps to sort of put some context around that. It's a very moving story, very powerful story, and it speaks very closely to what we're talking about today, I think. So I hope this plays. And I hope that shortly you'll be able to hear this too. And Emma, if
6 years ago, I sadly lost my leg to cancer. It left me feeling that I didn't have any independence. And as a mother of 2 children, having my own independence and being able to do simple things with them, like going to the park or going to school, and, you know, doing that independently myself, to cooking in the kitchen, all these sort of different things, I felt like I'd lost everything. I think I had a week, didn't I? I think I had a week of independence where I was going out on this scooter and I was taking the children to school, and then it died and I didn't have the strength to propel myself. That then reminded me that I couldn't walk again, which then upset me again. I had a conversation with my children's school and I mentioned to them that I was feeling lost and lonely. I'd been through quite a lot of services, and I didn't feel like them services were providing me with the support that I needed. Didn't feel like it was working for me. I was then put in touch with Sarah, and as I say, 5 years ago, Sarah, well, I still remember that day. It was a bit, I didn't want to open my front door, but I did, and I'm glad I did, because Sarah came in and said, moving forward, what does your life look like? And what do you need to do to get to where you want to be? I think within about 3 weeks of meeting you, with small steps, I was in the community baking and raising money for another scooter with it, really, and that's what we did, didn't we? And well, with your help and your connections and introducing me to people in my village and getting me integrated into my community. And we did set up a community mobility scheme with a lot of the residents, and I'd had that form of independence back. With Sarah walking alongside me, I then decided, what did I want next? And I realised that I was somebody that wanted to be in my community more. I wanted to make new friends. I wanted to sort of rediscover myself and find out what my life would look like and what I was meant to do now. And the crucial thing was to find my new purpose. So with the help of the community health champions, I'd started doing these Zoom classes. I then did my training to become a level 2 chair-based exercise instructor. I wouldn't have done that had I have not had Sarah walking alongside me. It's about getting that right support at that right time and what feels like the right support for you. Quite often I find that as a wheelchair user, a lot of people kind of talk at me or talk to the person that's with me. I don't get that with the local area coordinators. They actually see me as a person that I am, and they spend the time to talk to me and ask me what I want to do. It's never being told, you need to do this is how you need to make your life better. It's what can we do to help you reach that. There's no right or wrong answer. Like if I say, you know, I want to do this, it's supportive. It's if that's what you want to do, then let's look at that. And then that in itself is empowering, because then that gives you that level of independence back. I mean, since I've been through local area coordination, my confidence has grown. I've now found myself again, and I know who I am, and I know what my life looks like. And you know, I'm still on this incredible journey, but I'm not doing it alone. You can do whatever you want to do. If you want to be, you know, for me, I want to be an exercise instructor. I want to help people get out more and not be isolated. I want to help people make more friends. I want to help people to just be themselves and do what they want. And I just wanted to be a normal parent. I now feel like a normal parent.
So with great thanks to Dee for sharing those reflections, and I think powerful testimony to what can happen with when you're able to draw upon, I suppose, the right type of support in the right way at the right time. The journey you can go on, really, especially if that is within the wider setting and context of your local area and community, which is what this is all about. It's very much underpinned by principles. These are the 10 principles of local area coordination, and we encourage all the local area coordinators to work from these principles rather than from a set of targets and KPIs. So I won't read through them all, but you can see that the notion of citizenship and relationships and community and contribution really, really fundamentally important to this way of working, this way of thinking, choice and control as well, another really powerful and important principle that we heard very clearly there from Dee's testimony. So what is it in terms of the design that's making this work? So firstly, I just want to point out these local area coordinators, as I've talked about, employed by local authorities, but they're rooted in communities, populations of 10,000 or so. So they are not too big, not too small. In terms of population size, they are accessible, well-known faces within that place. They're approachable and flexible practitioners who can anyone can draw upon and access if they want to meet with and talk with. And those introductions can come from anywhere. There's no referral pathway or process. There's no eligibility criteria that could get in the way of the starting of that relationship. And the local area coordinators are encouraged to take the time to get to know people, really understand what they're saying, what they're passionate about, what they care about, what matters to them, and their strengths and gifts, as well as understanding any of the issues that are getting in the way of that person, that family's vision of a good life, and really take the time to invest in trusting relationships. They see people as experts in their own life, and they see people as citizens and contributing citizens with gifts to share, rather than as service users or potential service users that need to be funneled through a system. And they focus very much on supporting natural relationships, helping people to develop their own networks, their own connections within the wider community before thinking about formal supports and services. So it's all about helping people to establish their own sustainable solutions rather than immediately going to the front door of services for support. So there's no time limit to it, there's limited paperwork, there's no assessment, and the LACs have this foot in both the local community and in the service system too. So they act as a very interesting bridge, working together to help influence the wider work within social care, primary care, and working within that whole system. So each LAC program that I showed you before, they have each one has its own leadership group that's made up of senior leaders from across the wider system who are interested and invested in that approach in place. They help people to coordinate their own plan, as we've been talking about. And finally, they work very closely with service colleagues too, ensuring that if people do need to draw upon supports, those supports are complementary to that individual, that family's vision of a good life, and ensuring that people stay in control. So that's the work, that's the role of the local area coordinator. And these are the things we support in terms of the design in order to get it right. So when Brian, you were talking before about really good people doing great stuff in spite of the system, I suppose what we're trying to do here is reimagine the system so that that is actually what the expectation is right from the start. And the impact, my final slide. Well, we see all sorts of different impacts. There's been 17 evaluations that have been done so far in this country. There's a concluding one led by, funded by the National Institute of Health Research. It's been going on for 3 years now. That's finishing up. That's the first multi-site evaluation. We're very excited about that coming out soon. But the impacts we see, it's about seeing the whole person, the whole family, and the whole community outcomes really. So it's helping people to achieve better lives. It's addressing those wider determinants of health inequalities. We heard from Dee, for her, that was about her sense of confidence, her sense of fear of what might happen if she were to reach out. And actually for her, it was about a relationship that she needed rather than the service at that point in time. It's about it. We see evidence of it promoting more inclusive, cohesive and connected communities. Local area coordinators only work in their communities. They don't have offices, they don't have bases. So they're just in the community all the time. So they really get to know everything that's going on there, but also helping to work with the community infrastructure, supporting that to emerge too. Dee's story, a great example of where someone was able to move from the fringe of their community because of their isolation and concerns to being an absolute contributor to it, a connected citizen able to share their gifts and talents with others. I think really importantly for the bigger picture, it's offering learning for wider change and transformation. So these leadership groups are really trying to learn how this is working, why this is working, what can we do differently within the wider system as a consequence of this. And we also see the evidence of it reducing demand on the system, as Brian was saying in his presentation. People no longer needing a service or no longer seeking a service as that first point of call, but rather identifying their own solutions from within their own life, their own network, their own community, and supporting others within their community too, and reducing that demand upon the system so that the services can be protected for when we really need them, rather than for them to be spending their entire time just assessing people for things they're ineligible for, which is part of the problem we see at the moment. So that's local area coordination in a nutshell. I hope that was helpful in this conversation. If anyone's interested in me, and if this speaks to any of you, please do get in touch. That's my email address. I'll stick it in the chat as well. And thanks very much indeed for inviting me along. I really enjoyed this so far, and I'm looking forward to the rest of the discussion.
Just unmute, Brian.
Thank you very much, Nick. That's great. A real insight into local area coordination and the impact it has on people and communities. Let's move on now to Dr. Guy Pilkington, a GP in Newcastle and chair of Ways to Wellness.
Thank you, Brian. Thanks very much, Nick. I agree. We're not a very diverse set of presenters, but hopefully there's some diversity in our presentations. And I'm going to just spend 10 minutes talking to you, no slides, about Ways to Wellness and what we did, and feel a bit of a fraud because what we're hearing so much from so far is about how if we are willing to encourage the locus of control away from systems and professionals to communities and individuals, we reap huge benefits for society as a whole and the individuals in it. But this wasn't quite the approach that we took. It all started with somebody that many of you will know called Chris Drinkwater. He and I worked together over many years, and we started the Ways to Wellness journey with a Nesta grant back in 2012. And with that, we did a bit of design work, working with the design school at Northumbria University and our community to talk about what would the kind of support you would benefit from look like, and what would those pathways be, and how would we create what has become social prescribing link worker model that we're all familiar with now. What would that look like in the West End of Newcastle? Because I continue to be a GP working in the West End of Newcastle. We were originally a primary care group. I can't remember what we were called before we became CCGs, and then we became a statutory CCG. Chris continued to work in the background trying to encourage these ideas, and I became the chair of Newcastle West CCG. So I became a key commissioner as we built Ways to Wellness, and building on the development work we'd done very actively with people in the West End of Newcastle. Chris essentially came up with the hypothesis that if we could make as routine as possible that individualized, personalized support for people, could we demonstrate beneficial impacts for the NHS to encourage them to routinely invest in this kind of support? And the hypothesis that included, let's work with people living with the classic long-term conditions that people will be familiar with, ranging from diabetes to heart disease to the respiratory conditions and so on. If we can routinely offer support to this cohort of people, can we demonstrate benefits for the system as a whole? In order to do that, we hypothesized that we would have to make the whole project so large that people couldn't ignore it, that we had to make it so routine and embed the cultural shift required for practitioners in GP practices in the West of Newcastle. So we needed a long-term contract, we needed significant investment, we needed to create a significant workforce. And some of the unique aspects of Ways to Wellness were that we had a social impact bond at the start. It was a 7-year contract that the Newcastle West CCG executive and board signed up to. It was an outcomes-based contract, a variety of things that were important. In terms of Brian's challenge to say, how did we rise to the conundrum of creating evidence? Well, what we ended up doing was working with our commissioning support unit, who were hoovering up data about health activity and spend and so on. We created the intervention cohort of 14,000 people registered with our West End practices, living with these long-term conditions, and we created a comparator cohort of 11,000 people living in the rest of Newcastle, similarly matched for age, a number of conditions and deprivation in the wards in which they lived. And we tracked activity for the next 7 years, interrupted a bit with the pandemic. But what we found was, and the outcomes contract and funding the whole project was based in large part on shifts in activity. 70% of the funding for the programme was contingent upon measuring an impact on secondary care spend on these two cohorts. And what we found was, for the years leading up to the initiation of the project, the cost of secondary care activity varied by about 1% between the control and the intervention cohorts, continued to run at about 1.5% for a year or two as we started the project, and activity gradually grew. And then we started to see a divergence. That I think year 3 was about 4% difference, year 4 was 8%, year 5 was approaching 10%, and the trajectories were pretty convincing. The most important element of the variation in activity and cost as a result was around emergency admissions. So we saw, because an emergency admission at that time, using what was called payment by results, would average something like £2,000 for a 5-day stay in hospital if you had an exacerbation of your chronic obstructive pulmonary disease or whatever it was. That drove the spend variation, which by the time the pandemic hit and everything became a little bit peculiar, by the time the pandemic hit, that 10% variation was equivalent to not far off £2 million of hospital activity spend. Subsequently, we've looked back at a number of things. Unfortunately, when we set up, clinical commissioning groups had no responsibility for primary care budgets. So we didn't incorporate any measures of primary care impact, whether that was activity data or anything else. That was clearly a weakness looking back. And more recently, and this is unpublished data, I ended up speaking to a research scientist with our regional prescribing body, and she asked questions like, did you look at impact on prescribing, which we hadn't done. So she went back and retrospectively looked at the control and the intervention cohorts and looked at a number of quanta of drug prescribing. And what's really interesting about the work that she did was she found that for most drugs that you wouldn't expect to vary, things like ulcer treatment drugs, proton pump inhibitors, lansoprazole and omeprazole that you may well be familiar with, there was no impact on these kind of drugs whatsoever, but there were significant changes in 2 groups of drugs. There was a significant reduction in antidepressant prescribing within the intervention cohort, and there was a significant increase in use of diabetes medication in the intervention cohort, both of which are really welcome findings, in my opinion. It would seem to suggest that people were relying less on antidepressants. And one of the measures that we had from Triangle, the community interest company, the Triangle outcome star for long-term conditions was used, showing significant increases in personal well-being scores. And that would seem to tie in with the fact that people were using less antidepressants. And perhaps you could,
Guy, please.
You could hypothesize that people were also taking more care of themselves when they were living with diabetes. Perhaps their interest in managing their diabetes is reflected in the fact that prescribing for anti-diabetic medications increased in that cohort. So I apologize for having so little about community resilience within that, but I think, and we continue to see ourselves as a charity at Ways to Wellness that wants to explore this. I think one of the things that we bring to the table is this, which is, in order to influence the NHS should be investing in what we're hearing about today. They should. The evidence is strong. It's the right thing to do. And as Brian says, it's as cheap as chips in the great scheme of things. But we don't. So let's, our interest is, how do we convince the NHS to have more confidence in that? And I think Brian's comment about the power dynamic and the fear, I think, is absolutely spot on. But we're doing our bit, we hope, to try and create measurable impacts that might be of real interest to the NHS. Thank you. Oh, I'll just share a link to the 6-year report in the chat.
Thank you very much, Guy. That's very, very helpful, and thank you very much for explaining how you managed to do all that and the retrospective data, which is really interesting too. So that's very helpful. I'm sure there are loads of questions that we'll get to after the next presentation, which is Rhys Davis, and somebody else, looks like.
Yes,
which I hope you'll introduce. Anyway, Rhys is Service Manager, Community, Enterprise and Workforce from Somerset Council. So we're very keen to have, very different voices about this same arena of community strengthening. So welcome, Rhys. Thank you.
Thank you. And I'm joined, and it's I think the main event today is David here from Wivy Cares, and I'll pass over to David shortly. And Wivy Cares is if you want to Google it now, it's a community-owned, community-led structure that provides help, care, connection to local people in Wiveliscombe, a parish of Somerset, but David will explain better shortly. And thanks, Brian. So I'm part of the commissioning team, service manager, part of the commissioning team at Somerset Council. And I'll just give you sort of a bit of context before passing over to David to talk about, I suppose, a little bit growing movement of community action in Somerset. So I suppose if somebody else was sat here from Somerset, they'd say we do pretty well around communities, and our investment in communities in Somerset. We probably in our system invest 10-15 million pounds a year on prevention, early help, community services. But I suppose the key question, and Brian put it at the start, is that what percentage of that goes, is spent on people who have come together in an area to design, define and deliver their own interventions or their own support in that community? What percentage of that funding? And I would hazard a guess it might be less than 1% of that funding is around actual community-led support in Somerset. So we've got a system where I think a lot of communities and citizens are relegated to participants in programs around this area, and that we saw a huge obviously during COVID a huge resurgence in community action, and to a large extent, a lot of that has dissipated now in Somerset, which is a real shame. But what we have seen, and despite all of these odds, as Brian you mentioned as well, we have seen COVID, and regardless of that, places and people getting organised around the challenges around health and social care, around ageing, around health, around well-being. And I suppose in my role, I've been lucky to build relationships and connections and networks with some of these people and organisations. And what we're seeing in Somerset is that they, some of these small organisations have come usually around the challenges of adult social care, around actually how do we get people the right type of support, and how do we build care capacity. So how do we get more contributions from more people around everything from being a good neighbour to setting up a local enterprise or support or service, and how do we connect people on a local level to local support. This is the sort of things that we're coming across, and it pretty much all started with David here, and so I will pass over to David in a bit. But because David, in your town, you walked that path, you did that hard early graft from those community meetings and got everyone organised. We now have 9-10 other organisations that, through direct speaking to David and recognising what was possible, have all designed and developed stuff themselves. And I can say, well, actually, we don't fund it, we should do. And so, I can't claim any of this, but I want to pass you on to David now to, I suppose, explain a little bit of that journey and what you want from the system, really.
Okay, right. Well, thanks, Rhys, for asking me to join you today. Yeah, Withy Cares, it's belongs to a town called Witheliscombe, just west of Taunton. It's a fairly small community, but what I'm talking about is community, and I'm absolutely convinced what we're doing is transferable across country towns as well as more urban areas. Withy Cares is very definitely a totally bottom-up project. We've been established 6 years now, and so we've got fairly good evidence about the success and viability of us. And it started with a few public meetings where we were recognising a helplessness that we were getting from that there was in government, not just us, but the whole country. Helplessness of governments and government reports, with a failure to shift this issue over 30+ years. So we thought, let's get a few people together in the public. We had a couple of meetings and everybody supported us moving forward. We established ourselves as a charity, and throughout that 6 years we've had to apply for grants, which has been exceedingly boring. But hopefully there's a slight movement now to sort of recognising community projects and what we're doing for the health service and social services. As I say, our focus has always been on community, and that is our strength in delivering a fantastic service for all sorts of reasons. I'm going to list a whole load of reasons, and if you want, maybe I can let Rhys have a copy of them and we can always circulate them afterwards. So our focus all the way through has been on local clients, local carers for local clients. So that was an absolute given. They don't have to travel. They have the real connections locally. And this has enabled us to recruit. Now, recruiting carers has been a huge problem across the country, everywhere, even, where we were. And it has enabled us to recruit over 40 new carers to keep pace with increasing need. And we have more or less, for some reason, kept, more or less in touch with the referral rate. This creates more local employment for carers, receiving more appropriate levels of income, and they're still doing most of some of the most challenging work. Some of them go in and they're just sitters and companions, and some of them are clients are requiring, full-time care. And every carer will stay with the client full-time for each hour they're paid. The service is extremely responsive to urgent and crisis needs, so we are available 24 hours a day, 7 days a week. And we very rarely have carers waiting for a full care package or a part care package. Sometimes we can't get in a full care package right away, but we can get in we have a history of getting in a reasonable care package right away. And carers work the hours, so the requirements on the carers are totally flexible, and we've always been able, as I say, to sort of fit the requirements for care with the carer's needs. And this is better for stress levels of carers, managing their own schedules, and for the environment. The carers know of local support and local services better than anybody else coming in from outside the area. Local carers and clients have many people, history and other information to share, making it a more personable service. And I think, and we've not anticipated this, but we're absolutely sure this creates a stronger bond. And we've not actually had a single care complaint in 6 years, which is actually quite remarkable, I think.
Is it fair to say it's not just carers? You've got volunteers, you've got growing projects, you've got by putting that flag down, you were saying, who wants to make what contributions in Wiveliscombe, and you've got how many people totally, you've mobilised the big chunk of the community to give something back, haven't you?
Yeah, I've come this morning from a memory activity group which we set up, recognising the need for that. So Wivy Cares runs that, and it started very slowly, but it's now a thriving group, almost full to capacity. And obviously, we save a lot financially through all this. We have very little hospital bed blocking, and as far as I'm aware, we have nobody at the moment. It delays clients needing residential care, and we're absolutely convinced of this, but the problem is getting the hard evidence on this one. But we feel that's quite a substantial saving all round across carers, their families, local authority and health service.
Can I ask you to wrap up in a minute, please?
Yeah, well, I'll stop now if you like, and then you can ask any question.
Don't have to do that, but
I think the bit that is, it's around care capacity and connection, but it's the bit for me, and I suppose you're so entwined in Wivy, but if you look online now, there's Wincanton Cares who's set up, there's Carey Cares, and this isn't, this is, you've given confidence for communities to get involved in a space that historically they felt super nervous about. And
I should say we serve about up to 150 clients at any one time, and I'm absolutely sure over 90% of referrals for care come through Wivy Cares. The whole town actually knows about us, and actually sort of says, right, that's the first port of call. So that's Wivy Cares. There's lots more to it, and I'd love to talk for hours.
That's fantastic. Thank you so much. It really gives a absolutely dynamic and dramatic flavour of what it's like on the ground and what an impact that has on communities and demand and the whole flavour locally. Thank you very much indeed. Now, we've got 10 minutes or so for questions of the three speakers, so please feel free to chip in now. Don't be shy. Well, I've got some. Oh no, Helen, go ahead.
I was just thinking, David, when you were speaking of how important it was also to have that remuneration for local people to provide that service as well. So it's not just relying on volunteer or voluntary hours. And I was wondering, is that recognising that some people you can't just work voluntarily, you also need to have an income as well, or is that a different drive behind that?
Well, absolutely. You know, I think what we're able to do is mix and match the two. So we can have paid carers going into a client, sort of doing the getting up in the morning, cooking the meals maybe, but you can also get volunteers to go in more as companions, drivers, or what have you. So we're much more able to and flexible to provide a mixed service. I don't know whether that answers your question, but
I think from my perspective, I thought it was really important that it's not always a voluntary service. There are many people that would gladly give their time, but they're not in a financial position to be able to do that. And so to have that remuneration for some of the work as well is incredibly important to equalise who can do the work as well. I think that's my experience.
We've actually had a lot of people transferring from other work, you know. Our coordinator now, who's an absolutely amazing, we're very lucky. We've had 3 coordinators, and that's our only expense. And we've had 3 coordinators who are absolutely fantastic. But the present coordinator started a part transfer from working, you know, serving in a hotel and then working in a shop, local shop, and she's really now found her niche. And there's another one very recently, you know, has just been really anxious about making the switch, and they can do that step by step until they're confident they're going to get the work. And I think there's nobody actually that, as far as I'm aware, has given up because there isn't enough work.
Brilliant. Thank you.
Thank you very much. There's some very interesting contributions in the chat, by the way. I don't know if people have been following that. I'll get you in a second, Rhys. So I was wondering if someone, there's IFF Teams. There are a couple of references to Big Local, and I'm just wondering if someone wanted to speak to that. Because I think they've done an enormous amount of work in this area, and it'd be good to hear from you.
Yeah. Okay, it's Margaret Hanna here from International Futures Forum. I'm sorry I don't have a proper name on my Teams call. It's nice to be here. Nice to see Rhys and Sian. Adam, you're at New Local. This is your agency who did this report, but I'm aware of it from the Big Local's efforts to improve local health. And what's important here for me is that these communities were given money. They were given actual cash. They were given £1 million over 10 years, each of these hyperlocal neighbourhoods, areas. And they used that money incredibly wisely. There was some governance around it, but, you know, what was so gratifying for me to see was the way in which the decision making that they were making to prioritise, particularly children and young people, their mental health and well-being, diet and exercise, and they were very creative as well. And some of their solutions are obviously that where they were all low cost, they were making very good use of that money, and highly sustainable with a lasting legacy. So I think there's something very important in what was done there, and it's a great shame now, of course, that the whole program is finished in terms of local trust. But I feel that there is a legacy in those particular communities, and there is some indication that their well-being, against the backdrop of what you were describing, Brian, in terms of this cost of living crisis and economic decline, have actually sort of bucked the trend. And they've managed to improve their outcomes. So, yeah, just wanted to mention that one. Thank you.
Thank you very much. And I think, Kirit, sorry, is there someone else wanting to say this? Sorry, Rhys, can I get someone else to talk Kirit, you make the point about funding for communities, and you sounded quite angry, really. What? Tell us a bit about that.
Not angry. It's just been when you've been around. That I have been around the last 30 years, and focus when we talk about health inequalities. We need to look at that affects a number of different protected characteristic groups. That's something we need to look at as well. And constantly, what we get is short-term initiatives, peanuts thrown at short-term initiatives, not long-term. We're asked as small organisations to provide goodwill, and I say the goodwill is run out. We're not giving you goodwill anymore. What the focus should be now is how do we get the equitable investment, and that has to come across in terms of collaboration. And we've had to do it hard way. When I say we've just I'm working on a racial equity initiative called the Phoenix Way, and we've held different funders to account for their lack of investment on racialized, minoritized community organizations. As a result, we've managed to secure 50 million ring fence from the lottery, 10 million from the Youth Endowment Fund, and 3 million from Chanel, because the lottery and the Youth Endowment Fund were not reaching those small Black, racialized, minoritized community organizations in an equitable basis. So we've had to take it on our own, journey to try and create pots of funding, and now we're trying to leverage that. So this initiative is working across 6 regions. So going back to your point, Brian, the problem is national organizations, we need to have national partnering up with local and regional. So we need to have a better collaboration and joined up working, because otherwise what tends to happen is the NHS and other funders go nationally and then realize those national organizations don't have the reach at that local level. So then they try and, give us some incentives, which sometimes I say now it's got to be around cost recovery. If it's not about cost recovery, nobody's filling in my back time to kind of attend your meeting. Nobody's giving the backfill time has to be then. I think the comment that was made earlier in terms of volunteering is great, but we also need to, they have to be compensated as well. So I'm going to leave it there because I could carry on.
And I think that also emphasizes that we are really looking here at heroes who are doing some fantastic work, and there are short-term funding that helps people do this work, but we really need, if we want to take this serious, it's been like that for decades. At the same time, there are, there's sort of all sorts of initiatives spilling out. People are doing this sort of work all over the place. I was hoping to ask Jeffrey Berg, who I've not heard of or met before, to talk about health champions, but I think we have to move on. But there are lots of examples of this happening everywhere, but there is no systematic approach across the country, and that's what I think this meeting could possibly stimulate, put some pressure on to think about that in the future. And I'll I'll come back to that towards the end. So thank you very much to all the speakers. Thank you very much to all the contributors in the chat and those I've allowed to speak. And I'm sorry, Reese. But I think we're moving now on to breaking into groups and relying on Emma to sort us all out here. Just to emphasize, you're going to give us a little bit of a intro to this, Emma, I think.
Yes, I am. Hello, everybody. So we are going to go into breakout rooms now. You have 2 options to feedback. We would really like it if you could feedback on the Jamboard. If anybody doesn't know how to use Jamboard, we're about to put a link, and you should be able to access this Jamboard that you can see on my screen now. And to write on the Jamboard, you can see that I'm going to go over here to the left, press that sticky note, you can type away, and you press save. Now there's going to be 4 different 4 different rooms. You will see here, this is room 1, and then you click up here and it will move to room 2, and you can put your sticky note on there. If you don't want to use Jamboard, that's absolutely fine. You can just use the chat within your breakout room. So if you just bear with me, I'm going to launch rooms. Has anybody any questions on Jamboard? Is everybody okay with Jamboard? Okay, so this will happen quicker for some than others, but I'm about to open the rooms. So you're all about to disappear into rooms.
So just can I just say, Emma, just to emphasize what the question is?
Yes, of course. We're going to launch that as well. Yeah.
So the question is, how can ICSs and other elements of the health and public sector, so it's not just about the NHS, how can they create conditions for community strengthening, for community power to happen? So how can the statutory sector make this kind of work possible, easy and routine? So we're sort of looking for practical, maybe even legal changes that would make a difference. Don't feel constrained, but they should be practical, but they could be imaginative and dramatic, if you like. So, you know, do we want local area coordination in every PCN? Community development is a requirement for all ICSs. You know, we don't know, just it's up for discussion. But think how you and your organization can contribute going forward. So practical suggestions for the system as a whole, but also keep thinking, are there pledges that you could make later on? What are the kind of things that you and your organization could do to take this forward? And again, I repeat, if there is enough interest and passion in the group to start talking to government, talking to ministers, talking to the NHSE, then, you know, keep thinking about that, and we will try and draw that out at the end. So that's my intro to the questions. Good luck. I hope it goes well, and good luck with the Jamboard. I hope it works all right.
And when we come back into the main room, if you could nominate somebody within your group to feedback, that would be great. So I'm going to press open now.
Yeah, and we have very little time at the end to feedback, I'm afraid. So we're talking at, you know, a few minutes for each group. So, you know, plenty of time to talk, but when you feedback, please focus on a very brief presentation.
And how long do we have for this?
40 minutes.
40 minutes for the breakout.
Yeah.
Believe it.
So I'm waiting for you to move us all around.
Yeah, I think it's just taking its time. Are people getting any messages to say add room?
It says at the top of my thing, it says join room.
Join room. So that's what it's. We got out of the rooms. That's fantastic. Very impressive. I had a very good time in our room. I hope it all went well for others. So if we could have some brief feedback, need you to do it in about 4 minutes or 3 minutes each, if possible, and that would be great. And just again, a reminder that we're hoping you might be able either to, well, both to offer some commitments and pledges for what you might do in the future, and secondly, to think about whether you would be interested, available to work with others from perhaps this group and maybe other people to put pressure on NHS England and government to start systematizing the incredible insights that we've got from everybody here. So room 1. Who's going to speak for them?
I don't think we got to a point where we said who was going to speak, if I'm honest, but I don't mind feeding back if others are happy with that.
You're a great speaker, Gary. You'll do brilliantly. Thank you.
I'll be honest, I just looked at our Jamboard and thought, well, we're we good because we've got loads of post-it notes, and that bubble was burst when I came in here and found out that room 3 was populating our discussions as well. But thank you for that. Been really useful. Our conversations took us all over the place, if I'm honest. So we spoke a lot around the people that we had in the room, the organisations, and what support that they were providing at a national level, local level, system level, etc. And there is something in there in terms of us all coming together and having that knowledge, and we all have different knowledge that blending together is only going to be a good thing, isn't it? A couple of things that we specifically, we spoke about culture and culture change, and I think for people on the ground and for community organisations that are supporting them, there is a big thing around confidence and trust, and how do we build that? And that's not necessarily statutory organisations. And from an NHS organisation coming in and almost dictating what happens. It's about many of those community organisations and those people will work with organisations in their community rather than national organisations, regional organisations, or even ICBs or NHS coming in. So there's something about building that and what's the process that we do to wrap around that. We talked a lot about prevention, using the old adage of prevention's better than the cure. We spoke a lot in that kind of remit in terms of how do we keep people out of hospital, how do we reduce demand, conversations around actually what switches people on as well in terms of the investment. I think I mentioned that previously led to believe that stories and things that pull on the heartstrings is what matters the most, but actually now that I work for the NHS and not a BCC organisation, it's the pounds and pence, it's hospital beds, it's keeping people out of hospital that actually makes the difference. And then we talked about investment and effectively the money following the person. At the minute, there's too much money wrapped up in services and commissions, and actually it's not following the individual, or even we spoke about personal health budgets and money going directly to individuals to help them and support them in whatever it is that they need. We spoke about a lot of other stuff, but I will leave it there.
Thank you very much, Gary, for room 1. Room 2.
So I think I'm going to try and pull together the nuggets of our conversation. So we did have Brian in our room, who was very challenging and really sort of trying to get us to consider possible solutions rather than the problems. So I'm hoping that we have identified a few of those possible solutions here today. Similarly to Gary, we had quite a far-reaching sort of conversation, and what was interesting is there's a number of people in the room who have personalisation in their title. So there's that sort of real recognition that people who are involved in sort of personalisation are also very sort of interested and obviously embedded and involved and interested in the importance of sort of community strengthening and sort of supporting our local people. So I think that some of the key things that we identified was the importance of building on sort of incentives that are already in the system. So taking advantage of what's already in place. So thinking about possibly future iterations of the quality and outcomes framework and the sort of consultation that's been sort of recently sort of shared across the system, thinking about whether we can actually consider outcomes that relate to the system rather than just to sort of parts of our system. So encouraging everyone to work together, thinking about how possibly as integrated care systems are sort of CQC'd going forwards, whether there's some key lines of inquiries that we could sort of utilise working with CQC to actually measure the impact of integrated care systems on sort of community-led prevention types of activity. I think that there was something about having some really clear frameworks that sort of partners needed to sort of sense check themselves against, so kind of checklists. So, you know, when commissioning a service, have we considered X, Y, and Z that will help to improve community-based activities? So those were sort of some of the incentives that we thought we could sort of build on. I think there was something really important around empowering frontline clinicians to sort of raise awareness and sort of recognise the benefits of working with local communities. There was something really important about building trust, which, you know, you mentioned as well, Gary, that trust is absolutely key. And if we don't sort of trust the people to sort of deliver against work this types of activity, then we're never going to sort of get to a place that's going to be beneficial. We had some good examples around sort of health inequalities funds, some locally commissioned services that are sort of working to encourage general practice to work with communities. So there are sort of some good examples of sort of things that are happening in the room or in the systems already. I shall finish there and just look out to the rest of the room to see if there's anything that I haven't covered that anyone else wants to add.
But you did a pretty comprehensive job. Well done. Thank you, Katie. Room 3.
Yeah, hi. So in terms of themes, we talked quite a bit about, well, I guess the sort of two sides. So the action that's needed bottom up, really, in terms of communities, but then also needing to have the kind of shared vision and action top down. And in particular on the top down stuff, we were looking at, okay, how do we be useful to get leaders to go into communities more and to see and understand this. It would be useful to also look particularly at commissioning, because the whole point of ICBs now is to be doing that cross commissioning, but I don't think there's probably a good enough understanding of all the kind of component parts that we've talked through here. So particularly that how you kind of get that community driven services, I guess, by asking the community rather than deciding what it is you think people need. So how do we kind of shift that culture? We also talked about PCNs, but also the growth of the integrated neighbourhood teams and the likely kind of national focus on how we can use those in a slightly different way. And is there a way of connecting in the community connectors, for example, and others into that integrated neighbourhood team space? So instead of it just being health, clinical and non-clinical, we've kind of broadened that out and start to get those connections really working. So I think that's probably a key opportunity. And then I'm not sure this is very, very sort of solution oriented, but we just sort of thought it was helpful to reflect the funding position. So the struggles that VCSEs have got at the moment, the funding, and just how again our culture might need to change and rethink around how do we actually provide those services and those connections to refer people into in a different way. And I think partly that's going to come back down to commissioning, because we do have some commissioning examples where like health services are wholly local authority commissioned, or there's joint commissioning, but I think there's definitely a lot more to do in that space. And I think that was broadly it, but please, anybody else, if you want to jump in, if anything I missed, that'd be great.
Well done.
Thank you.
That's fantastic. So those are really practical suggestions as well that we could look at later. Room 4.
I think that's me, self-nominated. So one of the themes we came up with was, unsurprisingly, around funding and use of resource in terms of the way we contract for things, determine how those things are delivered, and probably no longer fit for purpose if we think of when the NHS was first set up and how things are much more based on wider determinants than infectious diseases. Also on a more local basis, using things like integrated personal health budgets. What else? Governance was another theme. So having measures reportable at board level for things like integration. So we know it's hard to do, but at the moment we're measuring more around performance than we are around integration. Or having more people from the community on the boards. Workforce was another one. So seeing training as a free good, thinking about either shared roles, rotational roles, or sharing training and educational assets across organizational boundaries. The VCSE voice was another theme. So VCSEs as sometimes a disparate group and sometimes small organizations as being a potential blocker. So having maybe a VCSE collaborative at a local level to provide that single voice. a theme around children and young people. So starting people when they're young get the most return on investment. We noted children's mental health is probably a good place to start. A nebulous theme I'm calling what do we want? What do we understand from? What do we understand of and want from community? So not everyone will have a common definition. I think even if we look at integrated neighborhood teams, everyone understands that to be something different. We talked about not forming those around PCNs, and we'll see how a policy emerges, but PCNs aren't necessarily indicative of the local community in some areas. What else? And then a final one we're calling philosophy of care / approach. So just the way that we're doing things doesn't seem to be working. We need to go back to basics. All of us as citizens with health needs. Yeah, I think that was it. Do jump in if I've missed anything, Team 4.
So just finish off about the philosophy of care. Didn't quite understand that.
I'm not sure I do either, Brian. I was rapidly grouping things together. So I think that might have just been one group where everything else, to the far right of our page, hence it's everything else that couldn't fit into a category.
Just to jump in, I think, because I wrote those words as the category, and I think what I meant was moving away from the philosophy of new public management to one which is a different philosophy of care, which is the step change that needs to happen, you know, that we've been talking about in terms of the wider metrics and understanding and proving and all that sort of stuff, but to have a different approach that is more
about building relationships rather than building transactions, maybe something like that.
Well put.
Okay, well, that's just a fantastic fantastic work. Thank you very much for the energy, the thought, the ingenuity of all of that. There are some very practical things that we can put to organizations once we pull all this together as a report. So there are two things I would like to ask. One is who would be interested over time, so there's no real urgency, I don't think, about this, but over the next 2 to 3 months to come together to think in more detail about what kind of a case we should put to either NHS England or a Labour Party or the current government about. I mean, we would need to organise these ideas that people have so clearly and very cleverly expressed into something coherent. You know, here are a set of options that the civil service could actually deliver. So, if you're interested in doing that, if you could please put your name or the email that you'd like to be contacted about. So I know that some people are here, although they come from various organizations, are representing themselves rather than the organization. So if you are interested in doing that, if you could put your email in the chat or send Sian and Emma an email to say that, and we'll over the next few weeks kind of gather you together. So that's one thing. So feel free, but I think it is a small commitment to start thinking about this in a more practical way. And then the other question is, what commitments and pledges might you be able to offer? This is work that you're going to be doing over the next few weeks or months that would move this agenda forward, either nationally or locally in your organization or elsewhere. Any thoughts? I'm sorry, I forgot your first name. My apologies.
Yeah, it's Margaret. It's Margaret.
Yeah.
Sorry about that. Yes. Well, this is great work, and it's been a really great afternoon. And I'm aware I did put something in the chat earlier about the IFF hosts a regular community calls and regular discussions around these issues, and we're looking to try and move into action over some of this work in a more deliberative way over the next year. But also, I do ally with the Community Orientated Integrated Care Network, which is led by Paul Thomas out of the Royal College of GPs. And they are about to launch a series of papers in the Journal of Holistic Healthcare around very, very similar themes. And they too are wanting to do something this year to up the profile for this kind of work. So there are potential partners in this field that it would be worth thinking about, so that it's not just one particular group or coalition. It's a networked group of coalitions, as it were. I wanted to just mention that.
That's extremely helpful. So would you be prepared to think about working with us, bring those, bring coalitions together?
Yeah. I think I need to make an introduction between Paul Thomas, the leader of this other network, and yourselves. And I think there are many people in this room and others who joined us for short periods of time and then had to go off, likewise are connected into lots of other networks who have similar philosophies. And I think there's something here about, finding ways for us all to connect and speak with a single voice about the importance of this work.
Yes. It's not easy to speak with a single voice with loads of coalitions, but that would be the task. So we will certainly be in touch with you. And I don't want to speak for the Health Creation Alliance, but that's certainly something that we as an organisation would be interested in doing as well. So thank you very much for that. Neil confirms that. Good, thank you. I was a bit anxious about saying that, but that's great. Okay, we've got some names for the lobbying work. Thank you very much, everybody. Keep going. So any other pledges or commitments or interest in taking this forward? Any other thoughts? It's tricky in the current climate, I know, to make commitments. Okay, well, for my part, I have been extremely moved and buoyed up by this discussion, and I think others have too. So not only is there a sort of community of spirit here, but it's the practical suggestions that I've found extremely helpful, and we also have people here that are actually doing the work. So they have found solutions. They found ways of doing this in a very, or a sort of increasingly inhospitable environment. And we need to learn from those people. I know who they are, and we'll be reaching out to them. I think what I hope we've started here is something, or continued here, is something that's really important and that can support each other, but also support the system in changing as a whole. So if there are any other comments or thoughts or contributions, please do speak now. Keep putting in any support for the lobbying work if you want. And don't forget, you can email us afterwards, either with pledges or interest or the lobbying support as you go through. Thanks very, very much to everybody who's contributed. Thank you very much to Emma and to Karen for making all of this possible. It's been amazing, and Emma and Sean, you've done a fantastic job. So thank you very much. have a good rest of the day. Safe journey home, as I keep saying to people. All the very best. Thank you so much. Take care, everybody, and do send us in any more lobbying commitments. That'd be great. Thank you very much. All the very best.
Thanks, everybody.
Thanks, everyone.
Thank you very
Bye-bye.
much. Thank you.
Bye.
Bye.
Bye-bye.